So there have been multiple developments, and we continue to see multiple developments, and we have seen some good news, bad news, and ugly news. I'm not going to talk much about the fee schedules, which are proposing significant cuts. Hopefully we will get over that. So there is no point in talking, and it's not helping anyone. And that is the contact information, and you can join the LinkedIn at ASIP or the PMCA and PMCOA and my personal one. And so is Dr. Sanapati's LinkedIn. Now we'll talk a little bit about opioid prescribing patterns. As you know, number of drug overdose deaths keeps increasing, but most of that is because of the synthetic opioids other than methadone, primarily fentanyl. But heroin deaths are increasing. Prescription opioid deaths, this is the prescription opioid deaths, is decreasing. Whereas benzodiazepines is also decreasing, but it is significant. Antidepressants. If you look at this, they removed marijuana from this because if you use marijuana here, you are considered as racist, I guess. In any case, there has been decrease, even though to 2019, because of the COVID in 2020, there has been significant increase in death rate. There is still death rate for prescription opioids is lower. So that doesn't mean I'm not telling you not to be careful. We still have to be extremely careful. So since 2009 to 2019, there is 35% decrease in opioid deaths. For 1 year from 2018 to 2019, 13.5 with prescription opioids. But for other opioids, there has been tremendous increase, 16% per year, total 1,134%. But if you just take from 2001 to 2019, it's close to 4,000%. Same thing goes for heroin, significant increases. So if we mismanage our patients, just imagine, so we are throwing them from prescription opioid group into fentanyl group or heroin group, and it gets contaminated. They think they are buying heroin or meth. It may be contaminated with fentanyl, and they will be dying. So that is where our patients who are dying comes from. So total number of opioid prescriptions have gone down significantly. It was 251,000 million in 2013, now up to down to 153 million, total 40% decrease. Even then, we are blamed, and we have to look at carefully. You need to learn the conversion factors. Transdermal fentanyl, 2.4. Methadone, up to 20 milligrams, it is 4 times. 21 to 40 milligrams, 8 times. 41 to 60 milligrams, 10 times. So it keeps increasing. Suboxone, we missed that slide. That also shows significant increases, very high level. So when we change the patients to Suboxone, we can always explain that it is a much stronger medication than morphine or oxycodone. So urine drug testing for adherence monitoring, these are the base guidelines. For a low-risk patient, prior to initiation of chronic opioid therapy, random testing 1 to 2 times every 12 months. Moderate risk, 1 to 2 times every 6 months, that is 2 to 4 times per year. Then high risk, 1 to 3 times every 3 months, that means we can do them 4 to 12 times every year. I know we have talked about this many times, but we need to keep repeating so at least we can remember part of it, if not all, because I'm still finding so much of confusion among providers, including the doctors. That is, so Noridian says that this is the LCD. Any additional, if you do more than that, you can still justify. But we never exceed those things, and we never bill them more than that. Now we have another problem. people are testing for high levels of THC. It may be coming from this Delta 8 THC, like Delta virus COVID-19. So this is prepared from hemp. So people are going and buying this extensively, Delta 8. So at our facilities, we are testing for Delta 8. Anytime their marijuana levels are above 100, we are going to go ahead and test for Delta 8 and check for that. So just looking at the gross numbers, don't go ahead and discharge the patients or withdraw the care. I will talk a little bit more about discharging the patients too. We are still not doing properly, and we are not following any. Some of the people are not following what we are talking here. Again, we have to do the SOAP. This needs to be revised once in a while. So we redo, revise. So you get much better score if you talk to them more, you get the answers. You write that patient is extremely anxious, has a lot of mood swings in the notes, but here, when you say, how often do you have mood swings? They say never. And this person says he smokes every day, but he stopped smoking 2 years ago. So we can't do that. We have to be extremely careful and change them. One of the questions here is that, did anybody get worried about your medication? They always say no, but you yourself were worried about it. So you can mark that, you change those things. Again, you go here, risk assessment, risk explanation, all the explanation is provided too in a long version. So again, look at the smoking. This is related to the metabolism, their anxiety levels. Are they asking for more medication? Give more points, suicidal attempts. So look at all these aspects and update it. And sometimes they don't tell you the first time, then they tell you later on. And your coding should be limited to this one, long-term use of opioid analgesic. Sometimes you can use opioid dependence uncomplicated if you are doing Suboxone induction or Suboxone maintenance, but main code is Z79, that is 891, long-term or current use of opioid analgesic. That is the only one you need. We don't want you to put 28 codes on there, only 4 codes. If you put a lot of codes, they will use only the top 4 and you don't get any credit. I see people marking all these things. If they are markings, half of them are not marking properly or not marking at all. So these are all the codes. So if you mark this and this, 136 and 137, you don't have to mark these 2, even if the patient has it. So you just mark these. Or if you mark facet joint arthropathy, that's fine, but you don't need any more than 2 in this. Remember, you already had 1 for long-term opioid therapy. Then you can mark another one, cervicalgia or cervical region spine, facet joint arthropathy, etc., or something here. It is very hard to find in thoracolumbar region. Most of your codes come from lumbar and cervical. And throw away all your old stuff. If it does not show pain in right shoulder, pain in left shoulder on the list, all the office managers, please look at it and throw the old stuff away. Keep the new ones. There are also more codes. If you don't have those, you can use fibromyalgia, chronic pain syndrome, chronic pain myalgia, multiples of these things. Understand the difference between chronic pain and chronic pain syndrome. Chronic pain is something they are coming to us. Chronic pain syndrome is chronic pain associated with multiple psychological problems. So unless somebody is psychopath or has major psychological issue, please do not use chronic pain syndrome. You can get sued for that. And it is very important to put all these codes, and these codes are only important for Medicare patients and Medicaid patients. For others, sometimes you can use other codes, but if you use these codes, you are sufficient and you are doing good. So our UDT algorithm is, if patients are receiving controlled substances, they can be classified into low risk, less than 7, moderate risk, 7 to 13, high risk, above 14. So we do UDT twice a year. If it is normal, that's fine. Go on with your life. Moderate risk, UDT 3 to 4 times a year. Normal, great. High risk, UDT 4 to 6 times a year. Normal, great. So normal, any risk, continue regular treatment. Okay, abnormal. So there are simple abnormal, any risk, and there is also complex abnormal. So continue therapy and repeat testing monthly for three times. Call in for repeat testing 1 month after the first abnormal. Okay, let us say we missed that. You can do it even after 2 months, but you can still schedule the patient to come back every month 3 times. So you can check and see. So what happens? So they are normal twice. So you can continue therapy and regular testing, or you can do extra testing. It doesn't matter if there is any question about it. Abnormal second time, or for THC, it is third time. So you start weaning process, but you also continue to testing. Weaning process is described here. You have to reduce it at a certain dose. Just don't say that I'm discharging you. You're not my patient anymore. Here is your prescription for 2 months and go. Here is your prescription for 2 weeks, go. Or reduce by 50%. That is not how you do it. Weaning process is a coordinated process. So during this process, if patient turns out normal 2 times, then resume the therapy and regular testing. You can post these things in all the patient rooms or wherever you want to post them so you can see them. Then abnormal twice, no opioids, but we can continue to test and also give other treatments. So complex abnormal is absent metabolites and or prevalence of other drugs, not just one, more than one. So directly go to no opioids, continue or withdraw care. So discharging a patient. So it is question is weaning or discharging, withdrawal of care, that is also considered as abandonment. So there are lots of lawsuits coming with abandonment issues with COVID-19. There are not many exemptions under COVID-19 anymore. They will be expiring soon. So we better be careful not to get sued under abandonment. So drug testing follow-up, if somebody tests for cocaine, that is misspelled, but methamphetamine confirmed above 92%, abused drug or absent metabolites, other drugs, THC more than 100 twice. So same philosophy, simple abnormal, any risk, continue therapy and repeat testing monthly 3 times. And if they're normal, continue therapy and do another once or twice if you think they are questionable people. Abnormal second time or third time, you start the same thing, just what I described in the other one. Complex abnormal, no opioids. So treating physician, not NP or PA, can take appropriate action or withdraw from patient care at any junction. Please do not discharge the patient. So this is a reasonable weaning dose, and you can put this in your chart or somewhere, get printed. And so if somebody is on Percocet 10 TID, this is the weaning process. Percocet 7.5 TID for 1 month. Initially, we thought maybe 2 weeks will be good enough, but it is not turning out that easy. So go ahead and treat them for 1 month like that. Then reduce further for another 1 month. Then go for 2 weeks. And after that, once daily for 2 weeks and stop unless they get corrected. Hydrocodone 10 QID. So hydrocodone 7.5 QID for 1 month, 7.5. So again, go same process, hydrocodone 7.5. So it takes 2.5 to 3 months. So if they're going to get proper, then they will be fine. So another favorite subject, documentation guidelines. We have heard this over and over. You have a tape And we sent you that. Hopefully you are watching, because it will be very important for you in a few seconds. I will show you in a few seconds. So the new regulations are again based on number and complexity of the problems addressed. They can be uncomplicated, exacerbated, or acute or chronic, and risk of complications or morbidity and mortality. You also have amount and complexity of data reviewed and analyzed. That gets somewhat complicated. So let us focus only on those two. That works for follow-ups as well as new patients. That doesn't mean that you don't need history and physical examination. It is essential to use history and physical as medically appropriate, but it is not used in code selection just because you met so many elements and so on and so forth. And medical decision making, you can use either level or total time. Either one is fine. So overall MDM elements is number and complexity of the problems addressed and risk of complications and or morbidity. So I'm not showing the low risk here. We will see in a few seconds, but majority of our patients are moderate risk. One or more chronic illnesses with mild exacerbation, progression, or side effects of treatment. If they have only low back pain, nothing else, they don't fall into moderate risk. They fall into low risk. Two or more stable chronic illnesses. If they have one of these two, then they become chronic level moderate, and eventually we can look at it, they go into level 4. Or undiagnosed new problems with uncertain prognosis, disc herniation, etc. for a follow-up. But for a new patient, these are all, even if somebody diagnosed, it doesn't matter, you're still diagnosing them. So that is considered as undiagnosed. So even if there is one problem, it still becomes moderate risk. We also don't know the progress. So the level of risk, all the diagnostic procedures ordered, as I said, these are all difficult ventures. We can't really meet the criteria, but management options selected, this is where our risk comes. Minor surgery with identified risk factors, like if we want them to have injection therapy. Prescription drug management, opioids, NSAIDs, anti-epileptic drugs, and benzodiazepines. So here we can look at it. Straightforward. Level 1, 99211, doesn't even apply anymore. So they don't pay for those things. 99201 is eliminated, it's not even there. So if you don't meet any of the criteria, they move you into 99211, and then they don't pay anything to you. So if it is straightforward, 202, that is minimal, one self-limited or minor problem. Then minimal risk of morbidity from additional diagnostic testing or treatment. For low, this is level 3, either new patient or old patient, the follow-up patients. Low, 2 or more self-limited or minor problems, one stable chronic illness. You see, somebody has chronic low back pain or chronic neck pain, only one problem. This is where they fall. This is level 3. Then risk of morbidity. Here you can give them exercise program, physical therapy, NSAIDs, ordering x-rays, referrals. If you do, that's all you do. Even if you have more problems, like four problems, but this is a low risk of morbidity, then you still fall into level 3. Level 4 is moderate. 1 or more chronic exacerbation, etc., or 2 more illnesses like chronic low back pain, etc. Again, we look into the moderate risk, prescription drug management, opioids, adherence monitoring, referral patterns, minor surgery with identified risk factors, or major surgery without identified patient or procedure risk factors. You just give them literature, that doesn't become risk factor here. But more importantly, nowadays under the new philosophy and Biden administration, Social determinants of health are extremely important. They have a difficulty housing. They have problems with transportation, income, racism, discrimination. So all these things count. They also count even for doing multiple procedures on one day. So what is prescription drug management? Just documenting reviewed, same, things like that don't count into that. If the provider is addressing a problem that includes continuing a prescription drug or refill in their education and medical decision making to manage the diagnosis, then it may be included in prescription drug management. Otherwise not. So we have discussed about this algorithmic approach for evaluation and management services. So the first, you have to list the number of problems. How do you list the number of problems? Don't list the problems until you look at your chart and what are the symptomatology? How many levels are there described in history of present illness? So based on that, you list the number of problems. After that, you check appropriate pain scales for all symptoms. Then do you have physical exam findings? Do you have proper diagnosis for those? Then only they count. Just pulling forward or polluting is not going to help you. Those are not counted. Like this is how problems are listed here. What else are we doing? Prescription medication management, adherence monitoring, assessment of treatments of effects of drug therapy, and pre-certification scheduling of interventional techniques. So we are going to discuss these risks. So look at the symptomatology. Before we marked those things, we looked at here. The patient has low back pain, neck pain, with all the factors, features there, and also has mid-back pain. So here, how much relief are they getting? This is the baseline scoring. Baseline scoring is always higher. Unless somebody just got into accident, broke a leg or something, then today's pain becomes higher, sometimes average too, but that is not a common thing. Most of the times, average score is, baseline score is higher. Then your average score comes, that is lower. And if somebody is receiving injection therapy for all three regions and it helped them pretty good, 70% for 2 months or 2.5 months and 50% for half a month or 1 month, the average scores will be 3. Today's scores, if you are repeating the injection therapy, that should be 5. But if you're not repeating the injection therapy, you're just seeing for follow-up, that will also be 3. And at the most, it could be 4 if they say pain is returning. So here, how much are they improving? More active and being more functional. But there are also other factors you can always look at. Are they doing any gardening, participating in sports, traveling? You get so much information. How are their grandkids doing? Are they spoiling them well or not? Are they having sexual relations? Are they watching movies or playing golf, fishing? We need to entertain all these thoughts. If they are able to do these things, that means you did a successful treatment. Medical necessity and level of risk. So this is medical necessity. You look at the percentage of pain relief, even though we looked at again, we need to look at here, this applies for both places. Pain scores again, how did the daily activities change? And are they meeting the medical necessity criteria? Why are we doing the opioid therapy or interventional techniques? Then they have to meet the risk assessment. Look at all the risk factors, risk stratification, prescription drug therapy, comorbidity assessments, and interventional techniques. So here we look into social determinants of health. We already discussed about that. Again, they are here. COVID-19, that is a special thing now. So this is the important quality of life, activities of daily living. So how are they doing? It is good, fair, or poor. Some people are very good, some are excellent. Work status, if they're not applying, working, not applicable, or disabled. But don't always write that worse than last visit. No change from last visit. Worse, worse, worse. no change from last visit. That really doesn't make any sense. You rarely write no change since last visit. If you're seeing a patient very frequently, somebody is coming for a stimulator or something, but if you are seeing for these patients for follow-up visits, there should be some improvement. If there is no improvement, just write no effect, but don't write worse. And that is very rare. And if you do write worse, you have to write a reason why. Due to new problem or due to the same problem. You also look at the medication management risk. Are they using illicit drugs? Are they using medications which are not prescribed, or not using medications prescribed appropriately? Is PDMP appropriate or not? Indications for interventional techniques. So this is very important. We need to mark appropriate ones. Just don't mark everything, only the appropriate ones. Somebody was last time saying that, well, then you will have the same thing all the time. If it is the correct version, it is okay to have the same thing. If you're copying, polluting, that is not okay. Tobacco cessation program, what are they doing with that? Non-compliance, discussion of comorbidities. This is the most important aspect. This is what saves you. What factors are interfering or can interfere or may interfere with your opioid therapy, obesity, smoking. So pulmonary problems, they may have sleep apnea syndrome, diabetes, illicit drug use, bipolar disorder, and other drugs taken, post-traumatic stress disorder, depression, anxiety. Okay, so if you don't want to do the radiofrequency neurotomy, this is where you need to document, but just don't mark and run away from there. Anxiety about the procedure is just not good enough. You have to discuss a little bit more about it. If they have a pacemaker or implant, you can mark one of them, defibrillator. Pseudoarthrosis, some patients do have pseudoarthrosis. If it is not demonstrated that they have pseudoarthrosis, but they had previous surgery with anterior and posterior fusion, things like that, you need to mark previous surgery with anterior and posterior fusion. If you want to add hardware, is fine too. So that makes it very important. Morbid obesity, unable to stop anticoagulants. Don't keep exactly the same language. Try to change it. Try to use what applies. The side effects with radiofrequency in the past, with irritation, swelling, or any other side effects. Don't say or any other side effects. You have to say swelling and add if you have some other side effects. Lack of response to radiofrequency in the past. So here, number 1 and number 2, and if you have anything else, you can add, and obviously they will have anxiety about the procedure. You can also add the same thing for why you can do multiple procedures on the same day. In a small percentage of patients, I don't know, it is 20 or 20% or so, you can do multiple procedures on the same day. And the same way, if you document properly, you don't have to do the radiofrequency, you can do the facet joint blocks. But because they are not allowing us to do multiple procedures on one day, then they have to come for multiple visits, so that becomes a little bit complicated. Also, decision regarding spinal cord stimulation, decision regarding interventional techniques. Okay, this is the one, the full one. You have seen it many times. So if you have audio and video, all insurers, if available, related to complexity, do not document time, generally higher payment. Audio only, just based on time. This is the management schedule. You have this slide we gave you before, and you can copy that again and use it any way you want to, but that is the suggested schedule. Telehealth visits, this is what you can all do. Audio only, audio and video you mark properly. So now we want to test your knowledge, how you are doing on these issues. So we are going to review a couple of questions now, and then next week sometime we are going to send you a self-assessment with 25 questions. Answer at your own pace. It doesn't matter. So you can go ahead and look at them and then answer them. But once you open that, you cannot close it. So you can't take 10 hours and say that you want to get paid for 10 hours. So you can ask me, what is the incentive for that? You get to keep your job. You are doing a good job, so you may get a raise. And you don't keep hearing from us all the time. And the another advantage for us is that neither Dr. Sanapati nor myself will have high blood pressure, strokes, or etc. This is the question you have. I want you to look at these things and try to answer. I want as many of you as possible to participate in this. So we will look into this. It is just a practice session. Whether you are professional or not, everybody can practice in this. Billing people, coding people also can practice, participate. So the most significant change in 2021 guidelines include a medical decision making based on key components of history, examination, and medical decision making. Medical decision making in 2021 will be based on number of complexity of problems addressed, amount and/or complexity of data reviewed and analyzed, and risk or complications or morbidity or mortality. Then MDM has never been part of algorithm for choosing a level of service, but now it is the sole determinant level of service. Based on 2021 level of service include number of diagnosis or management options, amount or complexity of data to be reviewed, and risk of complications and morbidity or mortality. So you can answer the question and then we can talk about it. The poll results will come out in few seconds. Answer 1, 2, 3. So 25% answered medical decision making is based on key components. So that was the old one. So that is no longer applicable unless you are working in an emergency department or some of those areas, inpatient. MDM will be based on number and complete 42%, and has never been a part of 8% and 25%. And correct answer is actually the B. MDM in 2021 will be based on number and complexity of problems addressed, amount and/or complexity of data reviewed and analyzed, and or risk of complications and/or morbidity or mortality, with meeting of 2 of the 3 elements. We just talked about that. I showed you that slide. That is what the correct answer is. Okay, next question. Prescription drug management documentation includes the following. The provider is addressing a problem that includes continuing a prescription drug or refill in their education and medical decision making to manage the diagnosis, routine follow-up visit with continuation of the current medication, monthly follow-up with renewal of medication, regular follow-up with no change required. So choose the correct answer. Again, I want to encourage everyone to answer this. Doctors, nurses, medical assistants, billing folks, everyone, whoever knows any of these things, or just for fun, what you just learned in the lecture or previous lectures. Okay, now the polling results will be coming soon.
Almost. There's still a few.
They're trying. That's a great thing. That's a good thing.
Yeah. All righty. Here we go.
Okay. Wow, that is so good. 86% answered correctly. The provider is addressing the problem that includes all the explanation, and rest of them, as I just showed a few seconds ago, are not applicable. So this is how the questions will be. They will be sent only to the providers, so nurse practitioners, physicians, and PAs. We can also send them to the medical assistants and billing folks if they are interested in answering them, but they won't get any penalty for that. So sharing.
Yeah, you should be able to reshare it. There we go.
So resume slides. Okay.
Yeah.
Okay, got it.
Yeah, perfect.
So procedural guidance. Again, we have to follow this KISS technology. Keep it simple, safe, and successful, or keep it simple, stupid. So if a patient comes with chronic low back pain, it can be somatic pain or radicular pain. Same applies for the neck pain and thoracic pain too. So I'm just going to talk about low back pain. So it would be a facet joint pain or SI joint pain. You start with medial branch blocks, or then treat or radiofrequency thermoneurolysis. Some people also treat with intra-articular injections. SI joint pain, SI joint injections, conventional radiofrequency neurolysis, or we can do the cooled radiofrequency neurolysis. We don't get paid much money, so don't do it. Radicular pain, a patient never had any surgery or post-surgery or spinal stenosis, we can treat them with caudal epidural, interlaminar, transforaminal epidural. Step 2, percutaneous adhesolysis. You can do percutaneous disc decompression or post-surgery spinal cord stimulation after everything fails, or intrathecal infusion systems. In a facet joint algorithm, you have to have diagnostic blocks when you meet 4 components. Axial pain more than 5, 3 months duration, failed conservative management, no untreated radiculopathy. I'm still seeing many patients with the diagnosis of radiculopathy and trying to do facet joint blocks. That is quite inappropriate, so we may get into trouble. So with the first block, you have to document that you had 80% relief, how long. If it is positive, it is positive. So if you had minimum block, but we prefer that they have a day or 2. Then you go into the second block, and this should be better than the first block. Second block is done with bupivacaine 0.5 ml, 0.25%. This is xylocaine 1%, 0.5 ml. If you did something different in your training, just change that to this. This is the standard. Then once they are positive, you can do the radiofrequency or therapeutic facet joint nerve blocks. You have to do them bilaterally at the same time. Right now, no other procedures with facet joint interventions, but if you meet the criteria, you show them why you need to do multiple procedures at the same time, you can do them at least in 20% of the patients. So if it is facet joint blocks, you have to document it is 3 months of relief. Therapeutic blocks or radio frequency, you had 6 months of relief. And if you are treating the patient after 2 years, the patient did not get any treatment for that region, so diagnostic blocks must be repeated. And how frequently, and those are all questionable. We don't know the answers for that, but I would just go ahead and wait regularly. But if they did not have any treatment at all for 2 years, I think you can repeat the block within 2 weeks, 3 weeks, 1 month, whatever the routine is. For me, after the first block, I wait 1 to 2 months and then do the second block. And after that, after 1 to 2 months, I go back to the therapeutic facet joint blocks or radiofrequency neurotomy. Now, mild sedation is permitted. You cannot give any opioids for diagnostic blocks. Contraindicated in patients with anterior lumbar interbody fusion or ALIF. So, therapeutic intra-articular facet joints are not covered unless you show why RFA cannot be performed. So these are all the reasons why RFA cannot be performed: pacemaker, defibrillator, implant, pseudoarthrosis. First four, you don't have to say anything else. You can just say that. If you want to document more, you can go ahead and do that. Then if you don't have this existing, you can pick up one of these, as I was discussing a few seconds ago, get one of these things going on. The limitations again, mild sedation, multiple blocks are not permitted except for up to 20% or so. That is the answer I got from the Medicare. And also remember, radiofrequency has a 10-day global. So if, let us say you did a radiofrequency on a patient 4 days ago, then you did spinal cord stimulation trial today, you're not going to get paid for trial unless you didn't bill for radiofrequency at all and did bill for trial. Will get paid for that, but otherwise you don't. There is a modifier, etc. We can work through that, but just it's best to avoid these things. If you are doing in a different region, you can use a modifier. So you can do multiple procedures if you have the appropriate pre-certification from Medicare disadvantage plans or Medicaid plans. Again, there are a lot of still issues continue with what we list, what we do, and there is no correlation sometimes between the consent and what was performed. Pre-certification issues, you cannot get a pre-certification for something and do another treatment. Other procedural issues, if it is United Healthcare, only 3 epidural injections per region in 12-month period. You need to observe all these important aspects. So there is a question about monitored anesthesia care versus sedation versus local only. Monitored anesthesia care is when you have a nurse anesthetist providing anesthesia. So there is a separate charge for anesthesia. If you just give sedation, you can call it moderate sedation or mild sedation, but we never bill for those because we really don't meet the criteria. So that is a sedation administered by RN or a physician in the operating room, or a nurse practitioner can do it, or a PA can do it too, but somebody other than the physician does it, or physician can do it too. Whereas local means there is no sedation at all. So who do we want to use for monitored anesthesia care? We have to be careful with all the new regulations. Monitored anesthesia care can be reimbursed only for patients for radiofrequency neurotomy, spinal cord stimulation, vertebral augmentation, or intrathecal infusion systems. So we don't want to use them for everything. There are a lot of disadvantages. One thing that we may get audited. So they may disallow the procedure too, because you didn't follow the guidelines, you did the procedure. You think that they are doing it, but we are also buying their supplies, etc. So we are still liable. And they can also get a bill. That will upset the patient significantly. So we have to be careful. In the facilities where we are doing these things, MAC anesthesia, don't say sedation, no sedation. It is MAC or sedation or local. So sedation or local will be into one group, MAC into one group. You have to bundle them. Radio frequencies and also stimulator trials, stimulator implants, vertebral augmentation procedures. Again, vertebral augmentation procedures, we want to do them only in an office setting. That is where we get paid most. So that is how we want to arrange. So that will be good for everyone and none of us will get into trouble. What is happening with COVID-19 effect on our practices? So a lot of people are losing, like physical therapy, 34% reduction, ophthalmology, 29%, dermatology, anesthesiology, everybody is 20% or more. So we are there ourselves too. And caseload is about 20% overall hospital admissions, and healthcare spending is down. So it is pretty challenging for us. So overall, new patient volume is reduced 20%. Established patient visits are reduced to some extent. Office procedures and ASC procedures are reduced 1 to 10% or up to 25%. 75% of the doctors say it is reduced 25%. So we fall into that group. So this is our data. We are doing somewhat better. If you compare them to 2020, we are 20% higher. If you compare them to 2019, we are 20% lower. So we are nowhere close to be catching up. So compared to 2019, even if we are exactly the same, that will be considered as pretty good, but we are not there yet. Or if you are doing 40 to 50% more than 2020, that is a good thing. That means we are breaking even again. So these are the data, and probably some of them doesn't make a lot of sense, but those are reductions in all categories. For some centers and some folks, there is more than others, and some are maintaining their lead. Hopkinsville, in March, they gangbusters quite a bit, 48 new patients. Now in July, only 30. So they're up and down like everyone else. Louisville is up and down. Madisonville, it is picking up again. Murray, not picking up. Owensboro, it is reasonable. Vincennes, Cordova, since we have a full-time doctor there, so it is significantly improving slowly. So we have to redesign our process for survival. We have to check eligibility, benefits, verification, pre-certification, pre-authorization, denial management. We also need to have a philosophy how we are going to help the patients who can't afford to pay the co-pays and deductibles. So we need to identify the patients. We need to expand our reach. We need to get for early referrals. We need to talk to people, manage them properly with all the stuff, what we have, maintain them as our patients. You don't want them to go next pain center, either because of a poor relationship, poor behavior, or not that we didn't offer correct treatment. Patient engagement strategies are extremely crucial. Costs of care, are we reasonable? Charging more is not a good thing. Health outcomes, patient experiences, these count. So engaged patients are much better. So we need to do more surveys. We have the new website. We have all these laptops and whatever we are supposed to be using. We need to use all those and do more surveys. So engaged patients are more likely to pay in full, twice more likely, 200%, 5 times more likely to recommend us to others. So here we go. That was the last words. So our survival depends on fear. That is, face everything and rise. That is what we want to do. Some people think we should forget everything and run. So we are not in that group. Hopefully none of you are in that group. Thank you.